హలో శ్రీకాంత్
సార్
ఇంకెంతసేపు ఆగుదాం?
స్టార్ట్ చేసా సార్. అరవింద్ స్టార్ట్ చేసా.
ఒక 2 minutes అవుదా? 8:05 మొదలు పెడదాం.
ఓకే సార్.
Good morning to all.
గుడ్ మార్నింగ్ మేడం.
Good morning, Shrikant. Good morning, sir. Omkar, good morning.
గుడ్ మార్నింగ్ ఉండదా?
Good morning, sir. Omkar, good morning.
అరవింద్ స్టార్ట్ చేసా.
Okay, sir. So, good morning, everyone. So, today we'll be talking about acute compartment syndrome and the effects of regional anesthesia or analgesia on the acute compartment syndrome. So, the main point over this class is that many of our surgeons, they express concerns against the use of regional anesthetic blocks for limb surgery after trauma. So this controversial discussion between the surgeons and the anesthetists, it does not always rely on a solid evidence-based background and is more based on possible legal consequences or on emotional grounds. So the main argument against this regional anesthesia is based on the delayed diagnosis and subsequently delayed treatment of compartment syndrome. To phrase it more provocatively or correctly, regional blocks are suspected to cause more damage in view of compartment syndrome. But from our perspective, the implementation of ultrasound or PNS guided blocks has led to the detection of anatomic structures and more success rates. So regional blocks can be considered as a reliable means to provide adequate analgesia for many of our procedures. Coming to a brief introduction of compartment syndrome, it is an acute condition of the limbs which Due to the increased pressure within a closed compartment, it compromises the circulation and function of the tissues within that space. It limits the local soft tissue perfusion to the point of motor and sensory impairment, leading to neuronal and tissue ischemic necrosis. Does regional anesthesia, does it lead to acute compartment syndrome? We don't have proper evidence. So it occurs most commonly in an osseofacial compartment of the leg or forearm, but it may occur in the upper arm, thigh, foot, buttock, hand, and even abdomen. The most common cause is trauma, usually after a fracture, and it also occurs in the context of reperfusion, ischemia, burns, and even poor positioning for prolonged surgeries like lithotomy position, and in drug-affected individuals, and also in snakebite. Coming to the pathophysiology, it is the result of an increased pressure in a closed and relatively inelastic osteofacial compartment. There is then a spiraling action that results in a rapid increase in pressure requiring early action. This increasing pressure, it reduces the capillary and venous blood flow, and the resulting tissue ischemia, it results in more and more edema and release of vasoactive mediators, further increasing the pressure in the compartment. This is all the arteriovenous gradient hypothesis, and there is also an alternative hypothesis, that is the ischemic reperfusion mechanism. Within both these hypotheses, there is increased pressure resulting in decreased capillary blood flow, decreased oxygen delivery to the tissues, and a resulting metabolic deficit. So in both, the pressure cannot be relieved until the inability of the compartment to expand has been resolved. So historically, the diagnosis of the compartment syndrome was always a clinical diagnosis, with compartment pressure monitoring reserved only for cases in which the diagnosis remained unclear even after the clinical examinations. So classically, 6 clinical signs or symptoms are attributed, which can be told by 6 P's. That is pain, cold, paresthesia, paralysis, pulselessness, and pallor. As perfusion to the affected compartment decreases, the lack of oxygen and the accumulation of metabolic waste products, it causes nerve and muscle ischemia and irritation, resulting in pain and decreased peripheral sensation. So pain out of proportion to the injury or clinical situation is often reported as the earliest sign of developing acute compartment syndrome. And pain on passive stretch of the affected muscle compartment is the most sensitive early sign. The affected compartment may also physically swell and become increasingly firm as the intracompartmental pressure rises. The loss of a pulse, paralysis, pallor, and decreased temperature are late signs indicating significant disruption to the vascularity and viability of the affected limb. As diagnosis should be made before the onset of muscle ischemia, these signs are not useful in the early diagnosis of acute compartment syndrome. Coming to the measurement of compartment pressure, it can be, the diagnosis of compartment syndrome can be particularly challenging in obtunded, confused, or uncooperative patients in whom the clinical signs may be impossible to elicit. Thus, direct pressure management is indicated in such patients, and it can be done using a variety of equipment and techniques like traditional needle manometry, multi-para monitors usually used to monitor arterial blood pressure, and dedicated transducer tipped intracompartmental pressure monitors. Single or continuous pressure monitoring may be performed, and an absolute value of above 30 millimeters of mercury in the normotensive patient is consistent with compartment syndrome. This value is further decreased in the hypotensive patient as the lower arterial pressure renders the limbs even more susceptible to ischemic injury. The obtained compartment pressure, it may be affected by the technique or the equipment used. For example, the use of an 18-gauge needle, it may lead to an overestimation of compartment pressure by up to 18 millimeters of mercury. So whatever equipment is used, pressure should be measured in the relevant compartments of the affected limb. So these are some of the techniques of intracompartmental pressure measurement. This is a wide side technique. It uses an intramuscular needle connected to connected to a perfusion line and a 20 ml syringe, which are in turn connected to the mercury manometer. Near-infrared spectroscopy is another non-invasive method suggested for monitoring the oxygen saturation of hemoglobin and myoglobin in the tissues, particularly at risk. So, and more recently, intramuscular pH monitoring has also been introduced as an additional diagnostic tool in order to accurately identify the compartment syndrome. This is another intramuscular pressure monitor by Stryker. This comes with a digital gauge. Now, coming to the question where to measure, and correct fasciotomy involves which compartments in the limbs. So there are several compartments in the upper extremity that when injured, they require fasciotomy in the arm, forearm or hand. The arm has particularly two compartments, anterior and posterior. The forearm has three compartments, the volar, the dorsal compartment, and the compartment containing the muscles of the mobile ward. These compartments are interconnected, unlike the compartments of the leg. So decompression of the volar compartment, it alone may decrease the pressure in the other two compartments, but still dorsal compartment fasciotomy should be performed. Coming to the compartments of the palm and finger, there are 10 compartments in the hand, the most prominent being the dorsal and the palmar interosseous compartments. The other compartments are hypothenar, thenar, and adductor. The compartment containing the adductor muscles of the thumb are often overlooked when doing fasciotomies, and there is no connection between the dorsal interosseous and the other compartments, and each compartment must be decompressed separately. Coming to the compartments of the upper thigh and the mid thigh, the thigh muscles are divided into three compartments, and they are invested by thick fascia, the anterior, medial, and the posterior. And because it is not common, it may generally go unrecognized. And in these patients, history of anticoagulant use is more common. Coming to the most common one, the lower leg, it contains 4 compartments, and each is invested by inelastic fascia, and each compartment, it houses a major nerve. For example, the anterior compartment, it houses the deep peroneal. The lateral one, it houses the superficial peroneal, the saphenous nerve in the superficial posterior compartment, and the tibial nerve in the deep posterior compartment. So the swelling in the lateral or the anterior compartment, it can compress both the deep and the superficial peroneal nerves against the neck of the fibula. The anatomy of the superficial and deep posterior compartments is variable in most patients, but both, especially the deep compartment, are frequently involved in the compartment syndrome. Coming to the foot, the foot has numerously rigid bound compartments, and even mild bleeding into these spaces can elevate the pressures dramatically. A wide spectrum of injuries can result in the compartment syndrome of the foot, especially crush injuries and those associated with multiple metatarsal fractures. And one more thing, the loss of posterior tibial or the dorsalis pedis pulse is very, very unreliable in the early diagnosis of compartment syndrome of the foot. So the earliest clinical findings are muscle and nerve ischemia and pain. And although this pain can be confused with the pain of the injury itself, it may be exacerbated by gentle and passive flexion of the toes, which stretches the intrinsic muscles of the foot. So, like I mentioned earlier, an absolute compartment pressure of more than 30 millimeters of mercury is the diagnostic cutoff for fasciotomy, and differential pressure threshold is the most recognized cutoff for intervention in the current use. And the tissue perfusion is affected both by the patient's diastolic blood pressure and the intracompartmental pressure. And patients with the increased diastolic blood pressure, they tolerate a greater increase in compartment pressure without muscle or nerve ischemia from hypoperfusion. And fasciotomy is done in those in whom tissue pressure increases to within 10 to 30 millimeters of mercury of the diastolic pressure with any of the other signs or symptoms of the acute compartment syndrome. And there is insufficient evidence for any single sign or investigation that are guaranteed to diagnose or exclude ACS. And hence, the gold standard is the measurement of intracompartmental pressures. And when in doubt or a high-risk patient, even continuous pressure monitoring may be recommended. Coming to the compartment syndrome in children, like in adults, 6 Ps was there. In children, 3 As, that is anxiety, agitation, and analgesic requirement. And the normal leg compartment pressures are higher than in adults. That is in adults, 0 to 10 millimeters of mercury, and in children, it is 13 to 16 millimeters of mercury. And these high compartment pressures combined with the lower normal diastolic blood pressure predisposes children to acute compartment syndrome. The threshold intracompartmental pressure is same as that of adults at 30 millimeters of mercury by direct measurement, or a difference between diastolic and intracompartmental pressure of less than 30 millimeters of mercury. So coming to the publications and recent articles on the effects of regional anesthesia on compartment syndrome, the available literature is by the lack of proper prospective and randomized control studies, and therefore a large number of case reports have been interpreted according to the author's bias. So I've selected a few publications that shed some light on how anesthetic techniques may affect the acute compartment syndrome. And in most of the medical legal aspects, almost 50% of all the cases and claims, they were ruled in favor of the patient. And several case reports still suggest that regional anesthesia may have delayed the diagnosis of the acute compartment syndrome. And there are also a few reviews which suggest that regional anesthesia may not mask timely diagnosis and may even facilitate the detection of compartment syndrome. So epidural anesthesia has been discussed in this one, and there are a few studies in which how a delay in the diagnosis of compartment syndrome due to the epidural masking pain has led to the long-term functional deficit. So this is a study. It was published in the Hong Kong Orthopedic Journal, and this is a case post TKR. And in this one, they have reported that they strongly emphasize that continuous epidural anesthesia is contraindicated in the case of complicated TKA because important clinical cues to neurovascular complications could be masked. They encountered a posterior dislocation, which is not a common complication of TKR, and this must be due to the delayed diagnosis of compartment syndrome, but still they are against the epidural anesthesia, which was given for the pain relief in this patient. Two further studies, they found that symptoms of gluteal compartment syndrome in 4 patients following TKR only appeared after the withdrawal of the epidural. And this is a case of compartment syndrome of the calf following TKR. And in this one, the authors reported that the symptoms of compartment syndrome following TKR can be masked by continuous postoperative epidural anesthesia. And in our case, given the severe consequences, post-op epidural anesthesia should be avoided after all types of orthopedic surgery of the lower extremities in order to allow for the early detection of the compartment syndrome. And this is a case report published in the Romanian Journal of Anesthesia. This is a case of a 19-year-old with a fractured right radius. He came in for a redo surgery for a malunion of the fractured radius. And he was proceeded for surgery under general anesthesia and a supraclavicular brachial block. And the surgery was uneventful, and half an hour post-surgery, he complained of severe pain, and the surgeon came and he just advised more IV analgesics and all, despite the functional fully dense block. And 1 hour later, when he complained of severe pain out of proportion, then he decided to cut open the cast. And after that, he found out that the limb was swollen, tender, and there was no radial pulse. And then he was immediately shifted to the OT, and a re-exploration was done under GA. and a large hematoma was evacuated, and a bleeding vessel was found to be the causative factor. So the hallmark is that the presence of an out of proportion pain with an odd distribution in the forearm, even in the presence of a dense and a fully established nerve block. And this is one recent case report blaming the continuous perineural blocks for delaying the diagnosis of compartment syndrome after distal femur and proximal tibial osteotomy. So in addition to the general anesthesia, continuous sciatic and femoral nerve blocks were run with ropivacaine of 0.2% after an initial bolus of 30 ml of 0.5% of ropivacaine through each of the catheter. And due to persistent breakthrough pain on post-op day 2, the surgeon performed a clinical evaluation on which he found that the gastrocnemius was swollen and the patient had excruciating pain upon passive plantar flexion and dorsiflexion of the foot. And the compartment pressure was then measured, and it was at 30 millimeters of mercury. Despite these findings, a reevaluation was performed 2 hours later, showing the same findings. And finally, an emergent fasciotomy was done. And once again, the breakthrough pain was ignored even in this case, and this delay had serious consequences like tissue loss and functional deficits. So this is another case report in which the patient was given continuous popliteal nerve block and was sent home on post-op day 1 with a popliteal catheter after foot surgery. And despite a dense sensory and a motor block, he was sent home. But pain became worse overnight, and he presented to the ER on post-op day 2. The cast was splinted but not removed, and no compartment pressures were measured. The patient refused to have a continuous catheter removed. The pain was eventually resolved, and on day 4, the catheter was removed. This is not a case of compartment syndrome, but of cast pressure pain induced by tight cast. So it could have even led to acute compartment syndrome. This is another case which describes a compartment syndrome after an ankle block for a revisional forefoot arthroplasty. The patient developed increased pain despite receiving supplementary analgesia, paresthesia, motor weakness, and it even showed a tense swollen forefoot with a delayed capillary refill. And no compartment pressure was monitored, and fasciotomy was done due to increment clinical signs. Despite the neglect of the typical clinical signs, the authors blamed the ankle block for masking the compartment syndrome and for delaying its diagnosis. So in none of these published case reports blaming regional anesthesia for the delaying diagnosis or therapy of the compartment syndrome, they can stand thorough study of the case if proceeded legally. Because in all the cases, ignored increasing pain and typical clinical signs were present, and not even a single case did analgesia block the area of the interest. So coming to pain relief after lower leg trauma, as everyone knows, pain relief is a fundamental human right, and the provision of effective analgesia should be there for all the patients suffering from any form of trauma. So if the injury is more prone to acute compartment syndrome, this human right is not affected, and the provision of pain relief should remain central. So regional analgesia is not the only form of pain relief, and even multimodal with NSAIDs and all other things can also be given. So even few follow that regional analgesia without the use of local anesthetic drugs like high-dose diamorphine or high-dose opioids can be used in the management of post-op pain. But many of the anesthetists, they still hold firmly to the view that regional analgesia with local anesthetic drugs and even single shot and continuous nerve blocks are the most effective form of analgesia. And most of them who provide regional analgesia, they currently choose to use lower concentrations of local anesthetics, and thereby preserving some sensation and movement and allowing the potential for the breakthrough pain. It should be noted that severe pain is not always a feature of acute compartment syndrome. Coming to the results in children, the European and the American societies guidance, they published in 2015 that there is no current evidence regarding the use of regional anesthetics increasing the risk of acute compartment syndrome or delaying its diagnosis in children. Hence, lower concentration of local anesthetics can be safely used for surgeries with an increased risk of compartment syndrome in children. And since the European and the American guidelines were published in 2015, there have been no case reports suggesting compartment syndrome in children associated with regional analgesia. So concluding this thing, the main risk factors appear to be age and male gender, and patients on anticoagulation medication, they have a high risk of thigh compartment syndrome. And this scenario must be approached with a high index of suspicion. And the communication between the anesthetist and surgeon remains to be very important. And since this compartment syndrome is primarily a surgical diagnosis, and therefore patients with unclear pain must be evaluated by both the anesthetist and the surgeon. Therefore, regional anesthesia, it can only be considered to be associated, but not the sole cause of delaying the diagnosis. And even in the case reports that we have seen here, excluding the 2 cases with dense motor block after regional, there is no clear-cut evidence that regional analgesia has masked the important symptoms of compartment syndrome. Hence, prompt management, tissue monitoring, and lower concentrations and volumes of the drugs should be considered to make way for breakthrough pain whenever present. Thank you.
అరవింద్ గుడ్ మార్నింగ్. ఎన్ని గంటల
Good
తర్వాత
morning, sir.
ప్రొసీజర్ అయిన తర్వాత వస్తుంది ఎక్కువ?
Sir, generally it can come at any time, sir. Within 48 hours post-surgery also it can present, sir.
సో వితిన్ 48 hours.
Yes, sir.
సో మనం ఎట్లాగూ ఇవన్నీ అల్ట్రాసౌండ్ గైడెడ్ చేస్తాం కదా?
అవును సార్.
సో మరి అల్ట్రాసౌండ్ తో ఐడెంటిఫై చేయొచ్చు కదా?
చేయొచ్చు సార్. ఇవన్నీ all of these things can be identified, sir.
Any pain we have to suspect?
Yes, sir. The main thing is assessing the pain, sir, and the cause of the pain is compartment syndrome or the cause of the pain is the surgery itself.
Yeah, differentiation ఏంటి పాయింట్స్?
అదే సార్, breakthrough pain ఉంటుంది సార్. And the 6 P's that I've told, sir, pain, pallor, pulselessness, and cold, paresthesia, అవన్నీ కూడా differentiating features సార్.
Thank you, Arvind.
Thank you, sir.
మెయిన్ క్లినికల్ ఎగ్జామినేషన్ చేస్తే ఐడెంటిఫై చేయొచ్చు యాక్చువల్గా పోస్ట్ ఆప్ సర్జన్స్.
Yes.
Any more questions, inputs, your personal experience with compartment syndrome? Anyone?
Sir, actually we encounter